In this breakout session, let's meet the experts and sit down in this interactive panel discussion regarding functional dyspepsia and occult gastrointestinal bleeding. Our esteemed panelists are Doctors Frederick D. and Augusto Jose Galang. Dr. D is an active consultant in the University of Santo Tomas Hospital and is the past president of the Philippine Society of Gastroenterology. He is the past training officer of the section of gastroenterology at the University of Santo Tomas Hospital. He had his fellowship training in the gastroenterology at University of Santo Tomas Hospital and had his endoscopic ultrasound and therapeutic endoscopy training in Mumbai, India and Hamburg, Germany. Dr. Galang is the current president of the Philippine Society of Gastroenterology and is the current chief of the section of gastroenterology and head of the endoscopy unit in the Angeles University Foundation Medical Center. He is also the head of the NGAC Task Force Safe Haven COVID Quarantine Facility in Tarlac. This session will be moderated by Dr. Virgilio Lo Jr., who recently graduated from his fellowship training in gastroenterology in the University of Santo Tomas Hospital and is now a diplomate of the Philippine Society of Gastroenterology.
Okay. Good afternoon. Can you see my slide?
I can, Virgil.
Yes, yes, yes.
Okay. Good day, everyone. I'm Dr. Virgil Lo, and I'll be moderating today's session. We will be tackling the vignettes of common GI disorders, and we are very fortunate to have with us two very distinguished experts in gastroenterology who will be giving their inputs in our case discussion. I think it's actually a rare chance for us to be able to pick their brains and see how they dissect the cases. So before we start, again, here are the house rules. Please keep your audio and video muted, and two cases will be presented, followed by a Q&A session with the experts. If you wish to ask questions, feel free to type it in the chat box. And there will be an open forum after each case. So let's begin. For case number one, we have NS, a 40-year-old female nurse, Roman Catholic from Pampanga, with the chief complaint of epigastric pain. Her history started last 2015 when she experienced epigastric pain described as intermittent, burning, rated 2 to 3 over 10, and occurs after food intake. This was non-radiating and was associated with nausea, bloatedness, and postprandial fullness. There was no noted reflux symptoms, and the symptoms were not related to defecation, nor there were any changes in bowel habits. Since patient was a nurse, she self-medicated with omeprazole for 40 milligram tablet OD as needed, which provided relief. In the interim, she continues to have intermittent epigastric pain of the same character, about 1 to 2 times per month, which was relieved by omeprazole as needed. And still, she did not consult a doctor. Until 3 days prior to consult, patient still had epigastric pain, but this time the symptoms did not resolve with omeprazole, prompting consult at the OPD. For the review of systems, it was unremarkable, as well as the past medical history. The family history was non-contributory. The patient is a smoker of 30 pack years and a non-alcoholic beverage drinker. She denies illicit drug use, has a mixed diet with no recent travels and antibiotic use. The For the physical examination, the patient had normal vital signs, and the rest was unremarkable. For the salient features of this case, we have a 40-year-old female complaining of recurrent epigastric pain since 2015, associated with nausea, bloatedness, and postprandial fullness. She self-medicated with omeprazole as needed, which initially provided relief, but recently became ineffective. There was no noted change in bowel movements, no weight loss. She has a 30-pack year smoking history. For the objective findings, she had normal vital signs and an unremarkable physical exam. So let's proceed to ask the experts. Dr. D, what is your clinical impression for this case?
Well, let me ask you a few questions before I give you my impression. Is the patient taking any NSAID?
No, no, doctor.
No NSAID. How about aspirin or any other medicine for that matter?
No other medicine.
No recent intake of antibiotics?
No antibiotics.
No. Okay. All right. So basically, if you look at the case, this is a long-standing case since 5 years ago when the patient started to have epigastric pain. The quality of the pain seems to be burning and therefore suggestive of a stomach problem, actually, or upper GI tract problem. And therefore, I may think that this could be a stomach or esophageal problem at that, up from this point, no, at this point. To differentiate between the other diseases, this may probably not be reflux because of the absence of heartburn, which is the sine qua non symptomatology of a patient having gastroesophageal reflux disease. And therefore, I may end up with somebody having an acid-related disorder that may be present in the gastroduodenal area. In this case, with the presence of bloating and postprandial fullness, this can be anything, no? From a patient having functional dyspepsia to somebody with peptic ulcer disease, or even somewhere in the middle, someone with a really have a gastritis related to H. pylori infection. The long-standing history of pain may also suggest that this could be H. pylori related and not from other things. So therefore, in this case, I would strongly suspect that the patient may have a upper GI tract problem, acid-related disorder, whether it is secondary to functional dyspepsia or secondary to peptic ulcer disease.
Okay. Thank you for that answer, Dr. D. Dr. Galang, do you agree with Dr. D?
Hi, good afternoon, everyone. Again, thank you for this kind invitation to join this postgraduate course. But before I answer your question, I just would like to share with you that I don't consider myself an expert in GI disease. I consider myself still a student, maybe an enthusiast in gastroenterology. And for the attendees this afternoon who are medical residents and even medical students, perhaps you may just consider Dr. Derek D and I as older brothers ahead of you in the study of or the pursuit of the study of gastroenterology.
Touche,
Anyway,
Toti, touche.
yeah, yeah. Anyway, um, initially the because of these salient features that you have that are flashed on the screen, my initial impression would be somewhere like an acid peptic disorder or acid related disorder, which is the more common term that's being used. The long history of 5 years history of recurrent epigastric pain that is not radiating, which would, to me, would not mean that there is no upward radiation of the pain. So therefore, I am basically thinking of I have ruled out the possibility of GERD, which in some cases like this may be uh, overlapping with the simple acid related disorder. But if you look at closely at the symptoms of the patient, aside from the pain, the patient also shares with us her complaints of nausea, bloated, and postprandial fullness, which is actually more helpful to us if we want to identify and look at how the pathophysiology of her condition evolved. So I would agree with Dr. Derek Lee that this could be functional dyspepsia. Well, if we are going to use current classification, for example, based on the Rome 4, which our students and medical residents will be interested to study much later. Um, Functional dyspepsia can be in the form of like postprandial distress syndrome, or could be epigastric pain syndrome. But if you would like to closely look at the symptoms of the patient, the pain is somewhere started from 2 to 3 out of 10, currently around 5 or 6 out of 10, which is still not severe. And maybe with that, I would be closely leaning towards a possible diagnosis of functional dyspepsia, probably post-prandial distress syndrome.
If I may add, Virgil, although yes, I agree that you have this epigastric pain syndrome and postprandial distress syndrome, but in most of the cases, you have both. It's not perfect that one should be labeled as epigastric pain syndrome and another one as postprandial distress syndrome, because if you look at the criteria to diagnose this disorder, you would see that some patients may have an overlapping symptom, right, Toti?
Yes, I totally agree. Um, that's why in the approach, for example, if you would like to, closely look at the history of this particular patient, as what Dr. Derek D has explained earlier, we need to further delve into the characterization of the patient's symptom, and if there are any other, symptoms that might give us a clue that the patient is having overlap syndrome, which could be could overlap with GERD, or sometimes also overlap with IBS, for example.
Okay. Just a follow-up question to that. In your practice, how often do you see those overlap syndromes with dyspepsia?
What do you
Uh,
mean, Virgil? Overlap syndrome between epigastric pain syndrome and postprandial, or overlap symptom between GERD, functional dyspepsia, and IBS? These are different things.
Epigastric pain and postprandial distress syndrome, doctor.
Um, okay, Toti?
Okay, well, there is indeed a significant overlap between those two clinical conditions. But it is incumbent upon us clinicians to approach each patient who comes with us with these particular symptoms, for us to really ask direct questions to really identify if they are which characterization they really would likely fall into. The word there is likely fall into because, as what Dr. D has said earlier, there are many cases, maybe approaching like 50% of cases, wherein those two situations may overlap. So in my clinical practice, we have to uh, ask leading questions for you to be able to characterize the difference between the two. And sadly, of course, because of the complexity of the pathophysiologic mechanisms, sometimes it's really hard to identify a clear-cut classification of for which a particular patient falls into.
Virgil, because our title is from evidence to experience, right? So let me give you
Yes.
some evidence. According to some studies, the more common symptom of functional dyspepsia is really the postprandial distress syndrome. It is more common as compared to epigastric syndrome. About 60-65% of patients do complain of postprandial distress syndrome, and epigastric pain syndrome about 30 plus percent. If you get the overlap of these, somewhere between 15 to 20% of individuals may have both symptoms altogether.
Very good point that we have different subtypes of dyspepsia and there's significant overlap. So for the next question, how will you approach this case, Dr. Galang?
Okay. Um, okay, we already discussed the my initial approach to try to identify for which particular subtype or the closest diagnosis that the patient may fall into. But aside from that, in these particular situations or these particular conditions, I would like to evaluate the patient if the patient has possibility of psychological disorder or like anxiety syndromes, because as was evident in the history, this is rather a long history, like 5 years, recurrent. And initially, there was a response to her proton pump inhibitors, but lately there's none. So if she had ulcer in 2015, well, she would have probably developed some complications or led to further, conditions that have caused confinement because of complications. But it looks like the patient is a chronic condition, and therefore chronic condition with an acute exacerbation, for example, in the past 3 days, I think. So maybe if there is a psychological problem or disorder or anxiety, that is a very good point to understand what's the cause of the exacerbation of this particular patient. Second is since the patient is already 40 years old, I would personally consider her not that young and not that old, but because of his offer presentation for a like a 5 year history of pain, I would also would like to evaluate her for other possible symptoms that would help me evaluate if I will how aggressive I will be in approaching her. Like for example, the presence of other symptoms like dysphagia, which is also or globus, which are symptoms of GERD, or we know dysphagia is an alarm symptom. If the patient has some amount of weight loss, or maybe there seems to be like pallor or anemia, these are um, we consider them alarm symptoms, so that we could be directed to be aggressive in evaluating her, and he or she may not just be a case of functional disorder. um, at 40, you have identified that the patient has no family history of cancer. So I think I'm pretty much assured that maybe, okay, since my P is also normal, so I would rest my case that probably she will uh, be better managed at this point as a case of functional dyspepsia.
Okay. Dr. D, will you perform endoscopy in this case?
Well, that is very similar to the approach of what you're asking, no? So if I encounter this type of patient in my clinic, three things comes to mind. If I am considering functional dyspepsia and I cannot rule out peptic ulcer disease, of course, a few things would enter my mind. There are three ways of going around it if you have a patient with uninvestigated dyspepsia. This is what we call them because we don't have any investigational yet of the moment. So we call it as uninvestigated dyspepsia and not functional dyspepsia. We only call it functional dyspepsia if we already have a simple test like normal EGD and normal gastroscopy or normal ultrasound. So, in cases of uninvestigated dyspepsia, this is where the art of medicine comes in. You have three paths to go to. One, you can either test and treat. You need to say you test for H. pylori first using UBT, or probably because we're in the Philippines, I would prefer UBT or stool antigen test to test for H. pylori rather than serologic testing because of the false positivity rate of, because yeah, there's, it's something epidemiologic, no? So that is one, test and treat. And if it's positive, we treat the H. pylori first. Number two, you can go empiric, just give treatment. And number three, you can go and do endoscopy first. There's no right or wrong answer. Now, uh, so going back to the patient, because the patient is already 40, and according to Dr. Galang, which I agree, neither old, neither young, but because it's neither old, neither young, therefore my age is already old. I'm already old. So, all right. So, in my case, in this case of 40 to 50, I would also look at other symptoms. There's no alarm symptom that is clear. But one thing is present in the patient. The patient is not relieved by PPI now. Therefore, probably in this particular case, I would probably do endoscopy wherein I can test for H. pylori at the same time. But if the patient do not have a more severe symptom at the present, maybe I would just go and do test and treat. Why not just empiric therapy? That is because of some cost-effective study showing that test and treat is better as compared to empiric therapy. You test for H. pylori first. So what test to do? Yes, UBT or stool antigen test. And most of the time, there's a question here in the chat box whether H. pylori is usually chronic. That is what we usually expect among patients with H. pylori infection. Although acute H. pylori infection, it's difficult to study because, you know, we don't naman ask someone to take H. pylori and observe them over time. So we don't know really when they did catch that H. pylori because we know it is transmitted by fecal oral route. And therefore, for me, in this particular case, if I'm going to go back into the particulars, I may suggest endoscopy to her. That the reason behind it is that the patient did not improve now. This, yes, Dr. Ruiz, the smoking history is also a very important point because if we are looking at the smoking history, which may also be a risk factor for the development of malignancy, I would also probably do endoscopy in this case.
If the patient regularly takes NSAIDs, Dr. Galang, would you outright do endoscopy already at 40 years old?
Okay. Okay. The presence of a in the history of a regular intake of NSAID will drastically change the picture of how I am going to approach this particular patient. If that's the case, then I will proceed with doing endoscopy. But if there is no history of NSAID intake or even aspirin, for example, aside from endoscopy, I will also recommend evaluation with using an ultrasound, and will probably consider also basic liver enzyme or even amylase, just to check the patient for any possibility of biliary tract disease.
Okay.
Dr. Lo, there's a question here. I think we need to answer this. When do internists need to refer patients with dyspepsia to GI? I think patients with dyspeptic symptoms needs to be referred to GI whenever there is a warning symptom of the patient. The presence of blood in the stool, unexplained weight loss, the presence of anemia, the presence of a palpable mass, vomiting. These are all alarm symptoms that warrants further investigation. Or in patients wherein you already tried treatment empirically and it did not improve. In these cases, you may want to refer them to gastroenterologists. Dr. Galang, what do you think?
Yes, yes, I agree. I agree. Most cases of acid-related disorders may not necessarily be attended to by gastroenterologists. So it is for this reason that we are, trying to educate our colleagues on when is the correct time to refer. And I totally agree with you. As long as there is already the presence of alarm symptoms that Dr. D has mentioned, then it is prudent for us to recommend further evaluation by a gastroenterologist to make sure that this patient's potential diagnosis for a possible malignancy will not be delayed any further.
Dr. Galang, there's a question here about probiotics. What do you think? Do you give
Prob-
probiotics for dyspeptic patients?
Okay. I okay. It's if we are going to talk about evidence, I don't think we have evidence for a substantial response to probiotics. Of dyspepsia to probiotics. But if we are going to consider the use of probiotics, for example, in the context of other functional GI disorders like those that
IBS.
have symptoms of IBS, for example, for which these probiotics may help in so far as small bowel conditions are concerned, then it could be, or there could be.
Okay.
But in this particular case, I don't. I will not use probiotics. It's just my personal opinion. I have further plans to to how to approach this particular patient, but certainly not to start her on probiotics at this point.
Okay, thank you. And let me just clear, when we talk about IBS, we talk about lower GI symptoms. These are patients with symptoms that may is related to bowel movement, whether the pain is more severe or it's improved with bowel movement. That may actually be IBS. All right, and not functional or not dyspepsia. Okay.
Okay, let's proceed to the next question. EGD and ultrasound were done, which were unremarkable in this case. And how will you manage this patient, Dr. D?
I would check for H. pylori. I would test for H. pylori. In this case, I would get sample from the antrum and from the body. Or if the stomach is truly normal, maybe I would get sample and send for histopathology and tell them that I need to check for H. pylori. Because this, although endoscopically you might not find anything, but histologically you can find some form of inflammation, which can happen, right? So basically, I want to look for this first. If it's H. pylori positive, I will treat the H. pylori infection. Because look at the patient now. The patient is not improving with your medicines now. So something must be going on. Because initially it was improving and now it's not improving anymore. So that is one. So I would do that. Double the dose of PPI, maybe I won't. It's not the same as patients with GERD symptom. In GERD symptom, if you fail treatment, you can double the PPI. Why am I saying this? Because evidence tells us that for functional dyspepsia, doubling the dose or even the usual dose of PPI is not necessary. For example, the usual dose of omeprazole is 20 milligram once a day. If you give 10 versus 20, the outcome is the same. So you don't have to increase the dose. So I won't do that. So therefore, I would test for H. pylori and treat with PPI while searching, probably depending on the symptom of the patient. Meaning to say, what is more predominant? Is it the pain or is it the bloating? Because if the patient has postprandial distress syndrome, I may consider the addition of a prokinetic agent. Because from beginning, I was telling you that some patients may have an overlap of these symptoms. Some patients may predominant epigastric pain. Some may have predominant PDS. But we treat the predominant symptom. So it is important to talk to patients what is bothering them more. Is it the pain or is the postprandial distress syndrome? Because most of the time, and even for the response of PPI, it's not really so perfect. We get a response of about anywhere between 40 to 50% with PPI for dyspeptic symptom. So In this case, I would check for H. pylori to cut it short. If it is negative, I may try to give prokinetic agent first.
Okay, thank you, Dr. D. Uh, for the next question, Dr. Galang, will you combine PPI and prokinetics in this case?
Okay. Um, the management of this particular case, since the symptoms that are more pronounced as complained by the patient is epigastric pain, as well as I would believe postprandial fullness. And therefore, to answer this particular question, that if there is really a role for PPI and prokinetics in the management of this case, well, there are trials that have utilized the uh, the use of prokinetic agents in these particular cases, and in particular, patients with postprandial distress syndrome may respond to prokinetic agents. However, I just would like to caution that not all patients with postprandial fullness will indeed respond to prokinetics alone, and they may also need to receive proton pump inhibitors. Um, but before I would consider starting the patient on PPI and prokinetics, for example, in this particular case, since the patient has a negative endoscopy and a negative ultrasound, then I will at this point I'm going to reassure the patient that there is no mass or tumor, there's no organic disease that was identified. And I would still pursue the possibility of maybe some form of stress may be aggravating her symptoms. For all we know that stress can induce more acid secretion. And if the patient is anxious about something or anything, it may contribute to her particular symptoms. So even before I give medications, I would also advise the patient on some possible lifestyle and dietary modifications. Like for example, I will recommend avoidance of fatty or oil, or excuse me, or oily food, because theoretically they slow down intestinal peristalsis, and they may contribute to further symptom development. With regards to diet, a smaller and more frequent meals would probably benefit this patient rather than a larger meal for which patient is more predisposed to developing postprandial fullness, for example. And I agree that on what Dr. D has mentioned earlier, if the H. pylori is positive, then evidence has pointed to us that in about 10% of, I'm sorry, we will be able to treat the symptoms of functional dyspepsia in 4 of 1 case out of the 10 patients with H. pylori infection. So, with the answer to your question, the role of PPI and prokinetic agents, well, I will use them. I can consider using them both, okay, to control acid and at the same time contribute to improving her gastric emptying, for example. But of course, it depends on what is are there any other symptoms that is present in the particular patient? For example, if the patient has occasions of constipation, then maybe procalopride can help in this particular patient because it is a prokinetic agent. At the same time, it also has beneficial effects to improve patient constipation. Um, I think that's the answer to your question.
Very
Vir-
good point.
Virgil, so that people don't get confused, no? So that we don't get confused. Because certain guidelines are different. If you look at the Asian guidelines as compared to the American guidelines, they are different, and even European guidelines. The reason for this is that Virgil, kasi in Americas, they don't have much prokinetic agent. The only prokinetic agent available there would be metoclopramide and procalopride. They don't have what we have. We have domperidone, we have mosapride, etopride. Procalopride, metoclopramide. We have ondansetron, we have all of these prokinetic agents available. So it's different. So if you look at the guidelines for the US, they don't give prokinetics. It's going to be on the third, fourth line before they start giving. In Asia, the recommendation is to give prokinetics right away because we have this, because it's available in the country. So that is one of the major differences between the guidelines from Asia and from the Western countries.
Okay. Okay, let's proceed to the last question.
There's a question here. Have you encountered side effects of PPI? Dr. Galang, you have more experience than me.
No, not really. Okay, there are some patients who had complained of headaches. Some patients would have complained of abdominal pain, on the contrary, while they have taken some PPIs. It is what I would suggest is take note of which particular PPI have you prescribed or has the patient taken, because there is really a certain PPI that there are patients who complain of headache after taking them.
Yes. An additional complication that I see would be diarrhea. Some patients have diarrhea. Of course, we're talking about acute complications of PPI. There are, of course, chronic complication of PPIs that you may have read about. No? So we're talking about acute here. So, but in this particular case, you don't really give long-term PPI because these are patients with dyspepsia, functional dyspepsia because of normal ultrasound and normal endoscopy, and therefore you don't give prolonged PPI. And therefore, in these cases, we expect acute complications of PPI, which are not really so common, somewhere in the range of 8 to 10%, somewhere there. But usually it's manageable.
okay, thank you. So for the last question, what is the role of tricyclic antidepressants and SSRIs in the management of this case? Uh, Dr. D?
Well, TCAs are supposed to be pain modulators. In fact, Dr. Galang was alluding to the fact that a while ago about the role of stress, meaning to say psychiatric disorder, and that of the GI tract. We know there's a gut-brain axis, that can be affected in patients with dyspeptic syndrome symptoms. So therefore, in patients with severe pain, we're not talking about anything else, and the patient continues to have pain even with PPI, even with all the other medicine, TCAs is worthwhile to give. So these are amitriptyline, for example. There are data on this that you give half the dose of amitriptyline, half the dose as compared to the usual antidepressant dose of this medicine. It may modulate the pain. This is not really for the antidepressant effect, but this is just to attenuate the pain by making the nerves more numb. SSRI works the same way. Now, for postprandial distress syndrome, that's another story. But of course, there are medicines now that can be used. Let's say, for example, the one I forgot the name because we don't have it in the country. The one from Japan, wherein it improves the accommodation of the stomach. So therefore, if you improve the accommodation, then postprandial fullness would be less in this case. So mirtazapine is one of them that can also be used because it improves the accommodation of the. So it depends on the patient's symptom. In these cases, I suggest that you refer them to gastroenterologists because this is advanced treatment already. This is not the usual way of treating them.
Very good point. In refractory cases, we should already refer them.
Yes.
Dr. Galang, in your practice, have you tried TCAs and are they effective in functional dyspepsia?
Yes, I have tried using TCAs for a few patients. The problem is these are centrally acting agents, and the patient may develop other symptoms like drowsiness, dizziness, etc. and therefore and thus it may affect their willingness to take the patient for a longer period of time. The recommended dosing for this, as what Dr. Diaz mentioned, is to start a low dose and to increase it slowly. But we should remember that if we are going to start these patients on those particular agents, we have to give them for like more than 1 month, maybe 2 months, for example. And we should tell our patients that the response to treatment may take a while, and therefore it may sometimes affect their motivation to take the drug.
Agree.
Okay.
There's a
Thank you.
question here. How do you treat, Dr. Galang, functional dyspepsia overlapping with IBS?
Okay. Well, that is actually a real life scenario. Okay, so there are some patients who complain of postprandial fullness, nausea, early satiety, and also patient has bowel changes. So it could be really a possibility that aside from overlapping, but in fact, the patient may still fall within the realm of irritable bowel syndrome. And therefore, we can give some combination medications with this to address patients' irritable bowel syndrome, depending on which particular symptom is the most predominant. Um these particular cases are not very easy to handle, and I always go back to basics to reassure the patient. Once I'm sure that there is no organic disease, I am some sort of trying to give some my psychological treatment and assure these patients that there's no serious condition, organic disease to consider, and oftentimes it may be able to help your particular prescription agents.
Agree, Dr. Galang. These are very difficult to treat. The more overlap, if you have three overlaps like heartburn together with functional dyspepsia and IBS, they are very difficult to treat. And I would agree that, maybe reassurance, but even if you keep reassuring them, some of the patients keeps on, and sometimes if truly, you're thinking that there could be anxiety disorder or panic attacks, I refer them to psychiatrists.
Okay. So we're now in our open forum. There's only one question remaining. How often do you prescribe H2 blockers in your practice, and can this be taken long term? Dr. D, H2
I
blockers.
rarely give H2 blockers now. I would probably give H2 blockers as a rescue medicine for patients with GERD. But even if I give it, I don't give it for a long period of time because of tachyphylaxis. The effect of H2 blocker tends to wane after 3 days of continuous use. So it's not effective anymore. Therefore, in patients with acid-related disorder, wherein we need to give acid suppressive drug for a longer period of time, then I'm not really very fond of giving H2 blocker. Now, next question. When do we use H2 blocker? For patients, for example, with GERD, there is a clear data now. But for functional dyspepsia, I don't think H2 blocker works as well as PPI. And therefore, PPI would be a better choice.
Okay.
And most of the guidelines tells us that the drug of choice for functional dyspepsia is PPI. To treat peptic ulcer disease, also the same. In patients with ulcer already, whether in the stomach or the duodenum, still it's PPI. But to protect against peptic ulcer disease, for example, patients taking NSAID, you may give H2 blocker, but at a higher dose, double the dose of what you're usually giving. Okay, but of course, to be more practical, to give it once a day, I would choose PPI.
Okay.
Only for GERD, for me.
Okay. There's no more questions, so let's proceed to the second case. Uh, we have RV, a 55-year-old male businessman, Roman Catholic from Laguna, with a chief complaint of hematochezia. His history started 1 year prior to consult when he experienced epigastric pain characterized as burning, graded 2 over 10, postprandial, lasting for 30 minutes to 1 hour. And he also self-medicated with omeprazole, providing partial relief of symptoms. Until 2 days prior to consult, there was increase in severity of pain, now with a pain scale of 4 to 6 over 10 from the usual 2 over 10. He self-medicated with omeprazole, this time providing minimal relief of symptoms. And 1 day prior to consult, he suddenly have 2 episodes of hematochezia characterized as bright red blood, approximately 200 ml per episode. There was no dizziness nor diaphoresis noted. That prompted admission. For the review of systems, there was no weight loss. Interestingly, there is arthralgia in the left knee for the last 2 weeks, which he used naproxen as needed for pain. He's hypertensive on amlodipine. He had a CVD infarct last 2010, maintained on aspirin, 80 milligrams OD, with no residual deficits. He disclosed that he had peptic ulcer disease last 2017, and an EGD revealed a gastric ulcer, clean-based gastric ulcer in the antrum. H. pylori was negative and was treated with omeprazole for 8 weeks. He denies any previous history of GI bleeding. The family history, his brother had gallstone disease. And the patient has 20-pack year smoking history, uh, with significant alcoholic beverage drinking with at 40 grams per day, with last intake 1 month ago, and denies illicit drug use. For the physical examination, patient was conscious, coherent, not in distress, with a orthostatic hypotension upon examination. From 110, it became 90 on sitting, with slightly elevated heart rate and respiratory rate at 105 and 22 respectively. He had pallor and pale palpebral conjunctivae. For the GI exam, sa abdomen was flat with no scars, no visible vessel wall or pulsations, normal active bowel sounds, tympanitic. It was soft with epigastric tenderness on deep palpation, with smooth palpable non-tender liver edge with a normal liver span at 10 cm. On DRE, he had tight sphincteric tone with no mass nor tenderness and fresh blood on examining finger. So again, for the salient features of this case, we have a 55-year-old male with complaining of epigastric pain for 1 year, that and a recent episode, 2 episodes of hematochezia, recent naproxen use for 2 weeks. He is hypertensive, diabetic, and a post-CVD infarct maintained on aspirin. He he had peptic ulcer disease last 2017, which was treated. He is a smoker, alcoholic beverage drinker. For the objective findings, he had orthostatic hypotension, tachycardia, pallor, epigastric tenderness on depalpation with no stigmata of liver disease, fresh positive fresh blood on examining finger on DRT. So let's proceed to ask the expert. What is your clinical impression, Dr. Galang?
Yes, thank you. Okay, you can see the salient features flashed on the screen, and at this point, definitely patient has gastrointestinal bleeding, GI bleeding. So the next question to answer is this upper GI bleeding or lower GI bleeding? Now, patient presented with hematochezia. which is usually a sign of lower GI bleeding. But unless the patient has evidence of dynamic stability, that's where we consider the possibility of upper GI origin. Now, in this particular patient, patient has signs of significant blood loss. Not only has the patient passed like I think a total 400 ml of blood, but objectively speaking, patient has pallor tachycardia, orthostatic hypotension, and although the patient has no diaphoresis, but maybe there's no diaphoresis yet. Okay, so with the patient's history, pain, intake of NSAID, aspirin, history of peptic ulcer disease, well, in this particular presentation, I would consider that this patient has upper GI bleeding, probably peptic ulcer disease, based on history of epigastric pain, intake of NSAID, chronic ASA intake, history of smoking, and even past history of peptic ulcer disease. Now, are there any other possible causes of upper GI bleeding if indeed the patient has upper GI bleeding? Well, the patient admits to taking alcohol beverage drinking, but otherwise on physical examination, we don't see any other objective findings that the patient may have um, conditions that will lead to a variceal cause of the upper GI bleed. And therefore, most likely the patient has upper GI bleeding, probably peptic ulcer disease. If we are going to consider at this point the possibility of lower GI bleeding, for example, since the patient passed out hematochezia, we have to consider first peptic ulcer disease before we consider uh, a lower GI cause or source of the bleeding.
Okay. Dr. D, do you agree
Of
with
course,
Dr.
I
Galang?
would agree with Dr. Galang. He's my senior. He's 2 years my senior, actually. So I'm now 36 years old. So Dr. Galang is about 38, right, Toti? Yeah, okay.
Yes, yes, yes.
Anyway, I completely agree that in patients with hemodynamic instability, especially if they have, even if they have hematochezia, you have to rule out an upper GI cause first. But of course, you cannot rule out completely that it's not lower GI because significant bleeding may also reduce the blood pressure. The only reason why we need to rule out an upper GI cause is because if the bleeding is so brisk, and therefore we expect the blood pressure to alter and to be abnormal, and this is what is happening. So in the emergency room, if you see this type of patient and you are in a quandary of what the patient might have, you're not sure. Easy. Just put an NGT, diagnostic NGT. No? By putting a diagnostic NGT, if there's blood, then you're sure it's upper GI. If there's no blood, then probably it's not upper GI. But it is from a practical standpoint, or you may not do it at all, right? So it's up to you whether you want to do it or not. Basically, to do that would involve what treatment are you going to give, and you also have to remember that NGT tests may be wrong in about 16% of the time. It's not really so accurate, especially if the bleeding comes from the duodenum. You may have a negative test. Now, just a little bit of clarification. Yes, Dr. Galang was mentioning about liver disease a while ago because we're considering cirrhosis as a cause of upper GI bleeding. Um, you understand that there's no stigmata of liver cirrhosis. This patient has called this significant alcohol intake. So what is more important rather than the stigmata would be to look for signs of portal hypertension. These are important that may suggest that patient may have variceal bleeding. Two things to look into: physical exam, easy to do. You just check the throb space, whether it is obliterated. If the throb space is obliterated, there is splenomegaly, or there is the presence of vessels in the abdominal wall that is prominent, which are signs of portal hypertension. This should lead you to think that the patient may have variceal bleeding. Why is it important to differentiate between non-variceal and variceal? Because the first medicine that you're going to give would actually matter in patients with peptic ulcer disease bleeding, you may start them on PPI, IV PPI. In patients with varicose bleeding, you start them on vasoactive drugs like somatostatin or octreotide. Yes, I agree completely with Dr. Galang that I have to rule out an upper GI cause first. But in the interim, I would also prepare the patient for a lower GI endoscopy if necessary.
For the next question, how will you approach this case, Dr. Galang?
Oh, okay. For example, of course, a patient who comes in with bleeding and hemodynamic stability, we should stabilize the patient first. And since there is already a passage of hematochezia, then you have, consider transfusing blood already because the patient already has hemodynamic stability with the presence of orthostatic hypotension. Of course, we have to start the patient NPO, but we can already start the patient on IV proton pump inhibitors. The patient may not have stopped bleeding, and patient may still develop further bleeding episodes, and therefore the patient should be watched closely. Of course, the presence of, so the intake of aspirin will is a direct contributor to the possibility of causing the bleeding, and therefore we should stop this drug in particular. Now, I already mentioned that I will prepare the patient for blood transfusion part, but for the meantime that there's still no blood, we have to stabilize the patient with the use of our isotonic saline.
Okay. Resuscitation is key in GI bleeding. So the lab results came in the emergency room, which revealed hemoglobin of 8 normocytic normochromic, normal white count, and increased hematocrit at 0.50, and also slightly increased creatinine and increased BUN. ECG and chest X-ray were normal. How will you manage this patient, Dr. D, given
Well,
this finding?
well, from the beginning, Dr. Galang already told us that there is hemodynamic instability. So therefore, I have to be aggressive with my fluid. I prefer colloid over crystalloid if available. If crystalloid, then NSS would be best. But if there is colloid, it would even be better. Now, of course, because the patient is bleeding, I would give transfusion. And the main reason why I'm more aggressive with transfusion here is because the patient is taking aspirin, meaning to say the patient may have some form of heart disease. And we don't want to compromise oxygen delivery of the red bloods by the red blood cells. And therefore, I would transfuse blood apart from the ABCs that we're doing to the patient. Of course, I would keep the patient on NPO. That is clear. Kasi nga, we don't want the gastric acid to be active at this time. The main reason why we don't want the gastric acid to be active at this time is because, clot may form already in that particular area. And you don't want the acid to dissolve the clot. And that is the major basis why we give proton pump inhibitor. That is to stabilize the clot. We don't stop the bleeding, but we stabilize the clot once it is already formed. That is the main reason why we're giving it. So therefore, there's a question here in the chat box asking whether we should, how long do we keep on NPO? I would keep them on NPO. And as I mentioned a while ago, I may probably put an NGT in this case. I would. Not only because I want to know whether it's upper or lower GI, but if there is blood there, I would want to clear the stomach of blood before I would perform endoscopy. But clearly, as soon as possible, I would do endoscopy in this particular patient. Because in this particular patient, especially if it is non-varicial, we have to compute for the Glasgow-Blatchford score. And there's no doubt, the patient is has hypotension, the hemoglobin is low, the BUN is high. If you look at the patient already, the age of the patient, then clearly the Glasgow-Blatchford score tells us that this patient is high risk for doing endoscopic therapy. And therefore, I would already prepare the patient for a gastroscopy while doing
Okay.
the resuscitation and giving IV PPI. It's a debate whether you want to continue with the high dose PPI, meaning to say the drip, or you can give a twice a day PPI per IV. It's a debate wherein we can talk about it some other time.
Okay. Very good points, Dr. D. So for the next question, this has been answered already.
Mhm.
And I see a lot of patients receiving tranexamic acid. Dr. Galang, would you give it in GI bleeding?
Okay. Yes, I understand that tranexamic is rather tranexamic acid is rather popular, and historically speaking, tranexamic acid has been shown to reduce the risk of surgical bleeding and even bleeding-related death from trauma, for example. Okay. Now, but for GI bleeding, the what they call it, the benefit of tranexamic acid may be most pronounced when the drug is given immediately after the onset of bleeding, which in general for patients with upper GI bleeding, for example, this patient comes in with 1 day, for example. So late na yung tranexamic acid natin. So so what I'm trying to say is the benefit of tranexamic acid is most pronounced or maybe most pronounced when the drug is given immediately right after the onset of bleeding, like in those patients who are trauma or those who are bleeding, surgical bleeding, for example. But in general, for GI bleeding, it has been shown that tranexamic acid actually does not confer benefit with regards to reducing primary outcomes of death from bleeding within right from the start of the studies. So in general, um, we should be we should not fall our backs so hard against the use of tranexamic acid because there are a better choice for than giving tranexamic acid, like for example the PPIs. It has been shown by solid evidences that indeed PPIs are the drugs of choice in patients with upper GI bleeding, for example, simply because it can maintain the pH to above for and it protects the integrity of the blood clot that has formed on the site of the GI bleeding.
Oh, okay, next question. Dr. D, you mentioned placing an NGT. Would you place it in cirrhotics suspected of variceal bleeding?
Yeah. I'm not afraid of cirrhotics, putting NGT. The end of the NGT is blunt, and we don't have solid evidence that you can produce more harm. In fact, for patients with cirrhotic, I would rather that they have NGT because we want to drain the blood. If you don't drain the blood, you might push the patient into NSF if the patient is cirrhotic. But in this particular case, that is a hypothetical question because we don't think that your patient has portal hypertension here. So this is GI bleeding. But there's a question here in the chat box which I'd like to answer. Is there a role in giving ranitidine on top of PPI in this patient? Well, I don't do that because if you look at the pathophysiology or the mechanism of action of PPI, it blocks the final common pathway. And therefore, ranitidine may not be so useful. And also to add on what was discussed by Dr. Galang, yes, initially there was conflict with regards to the result with the use of tranexamic acid. But the bigger trial, was just released in 2020, I think, or late 2019, the HALT-IT trial already confirms because it is a multinational, multi-center study looking at the use of tranexamic acid for GI bleeding. It did not confer any additional benefit as compared to the regular treatment that we are doing. So tranexamic acid is not useful. But on the other hand, sometimes you're pragmatic, you don't have anything to give anymore, the patient continues to bleed. Maybe I will not fault you if you're giving tranexamic acid, but it is not the drug of choice. And also remember, there are a few case reports with the use of tranexamic acid producing coagulation, coagulopathy. And therefore, some patients with thrombotic disorder, you might put them at an increased risk. So it's a balance. Again, medicine is an art. Okay. Aspirin can be resumed once after endoscopy. After endoscopy, you do treatment. Within 3 days, you can start them on aspirin. But you do not wait for so long because studies have shown that the mortality rate with old aspirin for those who really needs aspirin, and therefore the mortality rate is higher. So we resume aspirin ASAP once endoscopic therapy is performed. So let me clear this up. I hope Dr. Galang agrees with me. When we talk about mortality, when we talk about rebleeding, it is not PPI that improves it. It is endoscopy, endoscopic treatment. So PPI, what we're doing is just to slow it down. But the more important treatment is actually endoscopic treatment.
Okay.
Okay.
Thank you, Dr. D. Dr. Galang, how soon should we do endoscopy in this case? EGD and colonoscopy.
Oh, um, I we should okay. Since this patient has a significant hemodynamic instability because of his bout of bleeding, then once we have started the patient on hemodynamic support, then we can already plan for the performing endoscopy on this particular case. Now, as part of our discussions earlier, we are not 100% sure that the patient only has upper GI bleeding or definite upper GI bleeding, and therefore we agreed that we are going to do both upper GI and lower GI endoscopy. So to answer the question, how soon should we do endoscopy? We usually do it the following day or within 24 hours. Right after starting hemodynamic support, starting the necessary things to maintain clot stability, and as soon as there is complement of appropriate complement of staff like nurses and endoscopy assistants, as well as the endoscopy team, then we should already plan to do endoscopy. In this particular case, both EGD and colonoscopy.
Dr. Lo,
Yes.
Virgil, in fact, there's a recent article coming from the Hong Kong group looking at this, the timing of doing endoscopy. And they have clearly stated there that there is no role for emergency endoscopy. So if you're talking about emergency, when we say endoscopy emergency, within 6 hours of patient's presentation. But urgent endoscopy would be better, maybe within 24 hours. So you can buy time. You can resuscitate the patient while preparing the colon. So when we do the procedure, you know, there's no difference with regards to mortality.
Okay, thank you, Dr. D. Uh, these were the results of the endoscopy. EJD showed erosive gastritis in the antrum. H. pylori, rapid urase test was negative. And for the colonoscopy, they only found a 0.5 cm sessile polyp at the sigmoid colon. Uh,
Sorry, Virgil. There's a question here again in the chat box because we're not going back. The question is about using vasoactive agent for patients with non-variceal bleeding. Well, in my readings, there's actually no role to give vasoactive agents like somatostatin or octreotide for patients with non-variceal upper GI bleed. In fact, they compare the use of PPI alone versus PPI versus that of these vasoactive drugs. There's no significant difference in the outcome. So vasoactive drugs are not necessary for patients with non-variceal GI bleeding. Dr. Galang, agree?
Yes, yes. Um, the the recommended approach to GI bleeding really differs when you consider variceal bleeding from non-variceal bleeding, and we know for a fact that it has been proven time and again that the IV PPIs, acid IV suppression, are the mainstays in therapy in patients with non-variceal upper GI bleeding.
Okay. So, Dr. Galang, given the EGD and colonoscopy results, what will be your next step?
Okay. If you can, okay, it's obvious that on the screen that the upper GI endoscopy only showed erosions here in the antrum. Uh, of course, we would consider that the duodenum was examined here is also negative, and thus this uh, just means that the site of the bleeding or the origin of the bleeding is not within the bounds of examination by both endoscopy, upper GI endoscopy, and colonoscopy.
So,
Now,
Dr.
please
Sorry,
take note.
Dr. Galang, sorry
Sorry.
to cut you. So you're saying that the endoscopic finding is not compatible with the presentation of hematuria,
Yes.
right?
Yes. The patient passed out to about twice 200 ml of hematochezia. And these particular endoscopic findings will not support that particular clinical scenario. And therefore, these lesions, although present and may be caused by, for example, the naproxen and the aspirin, but these are not the culprit to cause the patient's significant GI bleeding. Now, if we look at colonoscopy here, and this is a non-bleeding polyp. It's located in the sigmoid colon. It has been emphasized here that the scope was able to reach up to the terminal ileum, and in still there is no report of either a lesion or even traces of blood. Now, I just would like to emphasize at this particular point that it is very important to perform terminal ileoscopy while doing colonoscopy in this particular patient. Because even, for example, that you have found out blood in the colon, you have to make sure that if the blood is also coming from the terminal ileum or right up above the terminal ileum. So you'll be able to identify the possible source of, not identify, but have an idea of where is the possible origin of the bleeding. In this particular case, it seems that the bleeding is far below the duodenum when reached by the endoscopy and way up from the terminal ileum. So that's a very difficult condition to uh, approach to think about when you're pressed for with this particular case because the small bowel is very long and we have limitation insofar as if we want to have an adequate examination. So at this point, I would consider requesting for a capsule endoscopy to evaluate the small bowel. Now, I just would like to emphasize that um, capsule endoscopy is a diagnostic modality to evaluate small bowel for possible sources of bleeding, but it does not confer any option to apply any therapeutic procedures. So it's just to identify possible lesion or source of the bleeding.
Uh,
Thank you.
Dr. Galang, there's a question here.
Yes.
What is the target hemoglobin prior to doing gastroscopy or colonoscopy?
Okay. If you look at this particular case, for example, 8 grams hemoglobin, 55 years old, I think. Well, as soon as I have blood and the patient is stable, I can already do my endoscopy. We don't have a clear-cut target, for example, a level of 10, for example, before we start doing our endoscopy. It also depends on the urgency of doing endoscopy. For example, if your intention is a therapeutic endoscopy, which means the patient has active bleeding, and you consider that an urgent hemostatic procedure is needed, then as soon as you already have blood and the patient is not clinically unstable, then I can proceed with my endoscopy with therapeutic intention.
But that is with regards to this case. But probably the one who asked this question may have read something about restrictive transfusion. That is different.
Ah,
Restrictive
Yeah.
would be for individuals without heart problems. So they are usual, young, and all of this. We don't need to put the hemoglobin to 10. That is an arbitrary value. I don't know when did it start. That's an arbitrary. Our
Yes.
objective actually is
Yeah.
to provide perfusion, adequate perfusion, and not the numbers. Even at hemoglobin of 9, if the perfusion is adequate, they don't need additional transfusion. In fact, most of the studies tends to have a higher mortality on those wherein liberal transfusion was done. I mean to say, you keep on transfusing until the hemoglobin becomes 10 or 11 or even 12. So we don't do that. That's number one. Number two, it's even more pronounced, the difference in patients with variceal bleeding. So be careful when you transfuse, especially in patients with variceal bleeding. Okay. So, but let me ask you, Dr. Galang, you mentioned about capsule endoscopy. What if the unit or the institution where you're working, enteroscopy is available? So, enteroscopy, you can view the entire small intestine with a scope. Which one would you prefer?
Well, okay. If I have an available enteroscope in my unit, then I would consider using enteroscopy rather than capsule endoscopy in order for us to have the advantage of possible application of therapeutic procedure or modality, or if there is a finding of a lesion that I would need to have some biopsies, then it could be helpful also.
Okay.
Okay. Uh, the next question. Dr. D, would you also do capsule or would you prefer enteroscopy?
Well, it's a choice again. If enteroscopy is available, but on the other hand, thinking about it, where will you put the scope? This is an
Hmm.
acute process. Therefore, malignancy would be less likely. Kasi acute right? If malignancy, there could be patients, most of the time, I'm not saying it's absolute, no? Most of the time, patients presents with anemia rather than frank GI bleeding, right? Or cold GI bleeding at that. So in this particular case, it's a toss up whether doing enteroscopy or capsule endoscopy. But it's easier said than done looking at the entire small bowel using the enteroscope. Because as mentioned by Dr. Galang a while ago, the small intestine is very long and tortoise, it's about 5 to 7 meters long, in fact, by anatomy. So it's very difficult to examine everything using the scope. And it takes a lot of time to finish the entire procedure. So you have an option for endoscopies for us when we're doing this. You have two options. You can go through the mouth or go through the anus. But of course, if the lesion is closer to the upper GI tract, then you prefer to go there, to go there. So basically, to answer your question, it's a toss-up. If enteroscopy is available, probably I would do enteroscopy. But if not, then capsule endoscopy.
Okay.
But as mentioned by Dr. Galang, the limitations of using capsule endoscopy and the advantages of using enteroscopy for this purpose.
Okay, thank you. Okay, for the last
Let
question.
me add to that question the answer first. Also, with regards to the sensitivity of catching a lesion, capsule endoscopy in the earlier studies are higher, have a higher yield as compared to doing enteroscopy. Okay? Sige.
For the last question, a capsule endoscopy was performed which showed a superficial ulcer in the proximal jejunum. How will you manage the patient, Dr. Galang?
Okay. Okay. We should look at this scenario in this manner. Okay. Um, the patient has a superficial ulcer in the proximal jejunum. Um, for all you know, this may be caused by our aspirin or even the recent intake of naproxen, for which it's possible that this patient has other lesions in the other parts of in the lower parts of the jejunum. However, we are going to consider that this is what was seen on capsule endoscopy only. And then if you would like to look at closely on the on the capsule endoscopic finding, then you can see this irregular shaped whitish yellowish ulcer surrounded by slightly hyperemic um, mucosa. There's slight inflammation there, but there's no active bleeding anymore. At least I'm not sure if I'm seeing it correct. Do you agree with me, Dr. Derek
Yes,
D,
yes,
that there's no more bleeding right now?
yes, yes. In this particular area,
Yeah.
but of course,
Yeah, in this particular area, yeah. So if we are going to consider that this is the truth, then how we are going to manage this particular patient? Well, the bleeding has stopped. Okay, you'll manage the patient conservatively. You have to give antibiotics because the small bowel is prone to because of the resident bacteria there. It could promote bacterial translocation. Of course, at the back of my mind, what I'm thinking when I saw this particular picture is that there may be some other lesions below this particular level with similar um, lesions. Because if I'm going to look at this may not be the exact lesion that has caused the significant hematochezia. But in the absence of finding anything to explain the possible hematochezia, then we are banking all our hopes that this is indeed the real cause for the bleeding. Now, um, since this lesion is not bleeding anymore, and I would assume that we have already conservatized the patient and the patient is stable, then I will be conservative already. However, if the patient will continue to bleed or the patient will have um, recurrences of significant amounts of bleeding, or the patient will have hemodynamically, again, will be hemodynamically unstable, then I would consider the patient being managed by my other colleagues, like for example our interventional radiologists, who can do therapeutic, angiography and possibly address the source of bleeding.
I thought you're considering Crohn's disease here, Toti.
Well, if this is Crohn's disease, then I would consider there may also be other lesions below this.
And the quality is
So,
normal, right?
yeah, yeah,
And the ileum as well. But of course,
yes, yes,
it can still be something else rather
yeah,
than pointing out towards NSAID as a possible reason for this.
yes. We consider this the differential diagnosis. I agree.
Yes, because I would agree with Toti because 90 to 95% of lower GA bleeding that is stops by itself. So with this type of finding, maybe you can observe it. But there are a few studies looking at certain medicines for NSAID-induced ulceration. The pathophysiology of NSAID-induced ulcer in the small bowel is different from that of the upper gut or in the stomach. In the stomach, we talk about prostaglandin inhibition. In the small bowel, you talk about prostaglandin inhibition. And on top of that, you have bile, which can produce more damage. You have bacteria, which can produce more inflammation. And therefore, some studies looking at, for example, metronidazole has been used for small intestinal bleeding related to NSAID. And of course, now we have a cytoprotectant, which also have some studies. So I may probably try it. Let's say, for example, rebamipide in this case, because there's no other medicine that we can give for this. PPI will not work. Now, my major question here is this. Now, you saw in the stomach that there was erosion and you saw some damage here. Now, are you going to continue PPI knowing that PPI is also a risk factor to increase the risk of NSAID-induced jejunal or small intestinal ulcer, Dr. Galang? That is the concept.
Well,
PPI,
yeah,
kasi because of the reduction in the acid, increases bacteria, and therefore the bacteria increases the ulcer rate of ulcer in the small intestine. Now you have a lesion in the stomach. Would you stop PPI and just make this heal first, or would you change to another medicine, or what would be your plan?
Well, I personally, I wouldn't. I don't intend to stop the PPI because if I would, then those erosions in the stomach might be, might aggravate, and they may be the ones that will bleed in the future. But I understand your concern, and I would agree that the use of mucosal protective agents not only in the stomach but also has been shown to have some benefit to offer um, NSAID enteropathy and like this lesion, then I will be considering those particular pharmaceutical agents to be conservative.
By the way, when we talk about, we're not talking about sucralfate here because sucralfate is not
Yeah,
in the small bowel because it
yeah,
acid for it to become activated. So sucralfate is of no use here, right?
yeah,
So
ribamipide.
let me give you my let me weigh in on this and give you my 2 cents worth. Probably my decision here would be I'm looking at the stomach whether it's the one causing bleeding. If the answer to my question is I think the one causing bleeding is the small bowel, I may probably stop PPI first and give cytoprotectant agent
Mhm.
because cytoprotectant may help in the stomach and also in the small bowel for a while. Then eventually I would bring in PPI. That is what I will do.
Okay.
Yeah, okay.
Okay, I think that's the last question, and we're running out of time. Only 2 minutes remaining, so I'll just check the chat box. There are no more. Since there are no more questions, I'm formally ending this session. Thank you, Dr. D and Dr. Galang, for that very productive session. I hope the participants learned a lot from this session. Thank you.
Thank you, Dr. Lo. And of course, it's always
Thank
a
you.
pleasure to be with Dr. Galang.
Yeah, well, my pleasure and honor, Dr. Derek D.
It's a privilege to me to be ano, mutual admiration, pare. Okay. Anyway,
No, no, no. The pleasure is mine.
stage.
Okay.
Thank you, thank you, thank you again to the organizer.